Thank you very much, Chair. I do have a short presentation behind, but recognise that there is a significant winter plan pack within the papers today, which I will assume as read. I am seeking guidance from the board today with regards to assurance for the winter plan, setting out the strategic and operational framework in managing winter across Mid and South Essex for 25-26, and would require sign-off against our statement of assurance. I'll just take you through some of the slides to bring out some of the key items from the winter plan, just to bring this to life on the large pack that is present in the pack. Sorry, slides. Okay, fabulous. Thank you. So just to bring this to life, this strategic coordination for our plan, it will be led by the ICB, it'll be led by myself as the Winter Director for this current year. However, I have been supported by provider leads at both executive and director level across all of our providers at Mid and South Essex, who have been indicated as the individual responsible for pulling together their plans alongside colleagues within the relevant provider organisations. Overall accountability does rest with each of the system leaders, and boards have gone through their own assurance provider framework and signed off their own winter plans, which are contributing to the overarching system plan. I think furthermore, it's very clear that within the plans themselves, it's not only operationally how these are going to be delivered this year, but actually strategically, and how we are also going to ensure that we are going to be able to deliver our priorities for the UEC, which is the Urgent Emergency Care 24-25 plan, ensuring that we can deliver all of these priorities for our patients. From an operational perspective, in terms of how we are going to deliver this as we transition through winter, this will be led fundamentally by the System Coordination Centre. We are going into our third year of the System Coordination Centre leading winter, so they are now well versed and proactive in their winter management and being at the core of the function of this service. Within the System Coordination Centre, this year we are in a very privileged position whereby we are co-located with our integrated transfer care team, which is a multidisciplinary team across providers, which will support the discharge of our patients and flow of patients, and is also co-located with the Unscheduled Care Coordination Hub, which again is a multidisciplinary team supporting from attendance and admission avoidance across all of our providers. The System Coordination Centre is a 7-day-a-week service running from 8 until 6 p.m. and then out of hours. This is picked up by our ICB on-call directors and our provider on-call. So we have a 24-hour structure, 7 days a week, to support winter management issues. To support in terms of that real-time data, we will be using Shrewd Resilience, which is our tool which provides data across all of our providers with our flow metrics, but equally that inbound demand, our capacity, which will enable us to see where the bottlenecks are and how the System Coordination Centre can intervene and support with regards to flow to make sure that we can maintain patient safety and care across all of our partners. In addition to this, we have our EPRR team, which is our Emergency Planning, Resilience and Response team, which will be stood up in a major incident or any incident so that we can run incidents separate to the System Coordination Centre and manage both winter and incidents separately. In addition to this, our EPRR team also holds the portfolio of vaccination, which is one of the key fundamentals for delivering winter this year, to ensure that we've got vaccination coverage across our patient population and our staff as well. This is an overview of the daily structure, which is already in place, operational. This is the ICB leading from the System Coordination Centre, but actually the daily interface with our providers and our interface with our regional colleagues as well. Our priorities for winter this year, there are a total of 7. I've just talked through the governance on point number 1. 2 is prevention and vaccination and community care. It's really essential that we spread the message as much as possible and as widely as possible in relation to flu vaccination and how that is really important that we protect our patients and we protect ourselves and the well-being of our staff. Equally, the Unscheduled Care Coordination Hub is really vital to supporting that attendance avoidance, keeping our patients as well as we can and retaining them at home. And I should mention, with regards to vaccination, we achieved 65% last year. We need to achieve a minimum of 5% on top of that baseline this year. So that's 70%, but we still know that we can go further and we can go faster. And our campaign commences on the 1st of October, so we look forward to monitoring that on a weekly basis. Urgent emergency care performance is really important for our flow of our patients across the community, and that starts at the front with regards to attendance and admission avoidance, but equally the offloading of our ambulances and making sure that they are done in a timely manner, and the flow of our patients through our emergency departments and into our bed base and into our community. But most of all, that prevention, keeping patients well and keeping them at home. Mental health and integration and crisis responses, making sure that we've got sufficient capacity out of hospital and in hospital to manage mental health, and equally reduce the wait times for those patients waiting and reduce our out of area placements, keeping our patients within our local population. Discharge, admission and avoidance for flow. I've talked about the integration with our integrated care transfer hub and our unscheduled care coordination hub, and how it's really important that they work together to support that flow of patients and really continue to push forward with the discharge delay progression work that was put in place last year. Our delays across our system, and particularly Mid and South Essex Foundation Trust, are at their lowest that they have been since pre-COVID, and we've still got capacity to improve that further. We are integrating further workforce within this team. We have mental health that are supporting and coming into this team, as well as hospices, and having those conversations early, and further looking at how disciplinary team people within our unscheduled care coordination. For example, conversations have commenced in relation to geriatrician and frailty hotlines, etc. Digital and data improvements, expanding on the care record that we've currently got in place across Mid and South Essex, and allowing our again to be able to look at patients' care records and do to support onward care and ensuring that we can support them retaining in their place of residence, and equally looking at other technologies so that we can reduce falls and support that independent living. Workforce and resource management, ensuring that we've got really good, robust rotas, and that's for both clinical and non-clinical staff. But again, going back to vaccination, ensuring that we have really good vaccination programs of our staff so that we can maintain that staff resilience across our winter pressures. Within the plan, we have indicated that we've got some system risks. They fundamentally are demand, capacity, flow and workforce, and that's demonstrated through our provider risks that have come through as well. I've just pulled out some of the risks here, operational pressures, and again, the risks associated with that and the mitigations that I've come onto in terms of the priorities and how we're meeting those. I've also mentioned around the workforce shortages and sickness and the importance around flu and vaccinations to keep that resilience and support. There is also a number of refresher training courses that we have in place with regards to infection prevention control and how we're supporting our staff with wellbeing hubs and incentives to ensure that we look after those during our winter periods. Discharge delays and flows. We've got some really good processes in place as we head into this winter, and it's essential that we continue to maintain those and strengthen those, as I've indicated, with further workforce coming into those and vaccinations. I can't talk highly enough about the importance of vaccinations this year as we go into winter. Provider-specific risks, I'm not going to go into each one of these because actually, as I indicated, they do consider themselves around demand, capacity, flow and staff workforce. There are mitigations, however, there are some risks that I do just want to pull out. Our first is Mid and South Essex Foundation Trust, which is our large acute trust. At the moment, they have a bed model. We use their bed model as our barometer for how we will manage over the winter with regards to patient flow. At present, the deficit for the winter period ranges between -95 and -156. However, just to stress that that is taken over a 6-month period, and the 156 is the worst case scenario for January. I am going to caveat that we are currently ahead this year of our winter planning, so we wouldn't be this far further forward with our bed model. So this is the worst case scenario. The acute organisation, Mid and South Essex Foundation Trust, are working across the 3 hospital sites to reduce this bed capacity deficit, and we are certainly working with them as well as system providers and how we can support to reduce. So my recommendation would be that I come back to board in November to give a brief update on what this looks like and how we've managed to mitigate that further. You can see some of the interventions that are already taking place across the acute and across the system with regards to same-day emergency care centres. There are new same-day emergency care centres that are going into place across 3 sites. Orthopaedics is being one of those, and equally we're strengthening our ability to stream directly into some of these services. Ambulance services, we know the risks associated with not offloading ambulances and the pressure that puts in our community. Therefore, it's really essential that we utilise our unscheduled care coordination hub, call before convey, and that our paramedics do access this service and they support with the alternative urgent care pathways. And we are working with care homes as well, so that we can really try and support our care home patients retaining in care homes where possible. 111, IC24 is our provider, and surge demand. We appreciate that when we're going through periods of surge, our 111 providers really do pick up some of this additional demand. However, they have fantastic rotas, hybrid rotas, whereby they have the facilities to be able to work across different arenas and utilise different opportunities with regards to hybrid working, which gives that flexibility to log in and support just those demand management surge periods. So I'm not going to go through the others because they are more detailed in the pack, but as I've indicated, our capacity, demand and flow. We are in a better position this year to run winter. We have got lots of new interventions that have come into place, and we've got interventions that have matured over the periods as well. We've got really good system coordination and leadership across our system, and we have new appointments of managing directors at our acute hospital sites, and we've got designated executive director leads as well as the coordination centres all co-located. Our attendance avoidance and discharge coordination, I've mentioned some of the interventions that we've put in place there and the strengthening and enhancing for this year. We are seeing an increase in call volume coming in on a daily basis compared to last winter. Last winter, we circa 25 calls a day. We're now taking 50 calls a day, and we've had one day where we had 71 calls. So we anticipate this getting higher, which is even better in terms of maintaining our patients retaining at home. Urgent emergency care transformation. We've held a number of missed opportunity audits across our 3 hospital sites and our other providers to look at what's the other opportunities we can support. We've got Pharmacy First, which we are really going to be supporting in terms of a redirection model across our 3 hospital sites and our minor injuries unit to support transition to other urgent care pathways and streaming directly to services to alleviate some of those pressures off of our emergency departments. We've got some great digital opportunities coming into place. We have an ITK link development, which is going to automate all category 5 ambulance calls. That's our lowest category, that will go straight through to our unscheduled care coordination hub, which means we'll be able to support those quicker, and it will take away some of the demand management from our ambulances, allowing them to see those category 2 and those urgent patients. I've indicated about same-day emergency care expansion, which again is positive with regards to admission avoidance, and equally our acute medical pathway development. We've got a very successful acute medical referral unit at Southend, which has now been in place for a year, and has really reaped the benefits in terms of wait times for our patients and outcomes at Southend Hospital, which is being rolled out currently at Basildon Hospital. So next steps and actions. Thanks to providers, particularly EPUT and Mid and South Essex Foundation Trust, who have taken their winter plans through their boards and have gone through formal sign-off with the board assurance statement. Today, I'm presenting the plan to you for our ICB assurance statement to be signed off. We have a system testing exercise next week, quite an exciting time on the 24th of September. That's led by myself alongside East of England NHSE colleagues. We will be testing our plans against 3 national scenarios set by our national team, but we are also putting in some of the learning opportunities from our own learning last year. And I've got 56 leaders coming across from the system to that. So thank you very much for your interventions and support there. And again, we will be attending a regional and national review on the 7th of October, whereby we will be coming together as 6 ICBs to contrast and compare our plans and see if there are other opportunities within other ICBs that we can pick up on as well. Thank you very much, Chair. I'm happy to take any questions.
Well, thank you very much indeed, Sam. A lot of work's gone into that, and it's in some senses it's preparing for the impossible, because we don't know what the winter demand will be, and we get a particularly bad winter and so on. And for those colleagues involved in it, again, it's highly stressful. And for a moment, looking at that detailed schedule you have of what you're doing each day, I thought the first thing you were going to do each day was cuddles when I looked at it. but it says huddles, and I understand that. But I mean, very detailed. Thank you very much. Questions and comments from the board. Joe, Jeffrey, and then Mark.
Yeah, thanks, Sam. A really, really good plan. Very impressed with it. Just a couple of quick questions from me. In terms of the actions, interventions and expansions that the plan speaks to in quite some detail, is the majority of that, I take the chair's point about you can never completely anticipate what will happen, but is the bulk of that in terms of our planning funded within our existing budgets, would be my first question. And my second question, and then I'll be quiet, I promise. I'm interested in Shrewd Resilience tool because it comes up, it's mentioned an awful lot, and that's so I think the first I've heard of it. So is it a new tool? How is that linked to the stress testing? And there seems to be a high dependency on that. So are we assured, or can we be assured, that the tool is well proven? Thank you.
Thank you, Joe. In answer to your question, everything is funded. It's not reliant on any additional fundings coming down for this winter. So we have everything in place and it's established, which is really positive, except for some new models, as we've indicated, around the SDEX. So I'm confident with those services. In relation to Shrewd Resilience, it is a tracking tool of capacity and demand. We have all of our providers on Shrewd Resilience. It's a tool that's used by our national providers as well as our regional providers. We can see all 6 ICBs, so we can see with the pressure across all of the ICBs in the East of England region, and equally we can support with mutual aid, and they can support with mutual aid if required. It's real-time data flow in terms of how each of our providers are operating, and it is RAG rated against the national OPAL framework, which again is the operational pressured framework, and we can see exactly as the tidal is starting to rise and the interventions we need to put in place, which will be undertaken by the System Coordination Centre.
Thanks, Sam. I think Emily's going to give me a demonstration later on Shrewd, but it looks just first glance very impressive. Thanks.
Thank you, Jeffrey.
Yeah, thank you, Sam. Really good, great presentation and a plan as a whole. And also the provide of different plans as well. It's very good to see that as well. I think my question, if I may overlay health inequalities over all of this, and the extent to which we are targeting some of our outreach campaigns, and the extent to which we are working, for example, just to pick one, with our trusted partners and trusted community leaders. To what extent are we doing that? Because there's no separate provider plan for that, if you get me, yeah? But are you able to give some example of that? And will that part also be resourced satisfactorily, given whatever limited budget we are? Just a bit more detail on that around that. I can see that they are participating in some of the transfer of care hub, for example, but in the vaccination, how are we dealing with that?
Yeah, so we do have a separate vaccination strategy, similar to the winter group. We have a vaccination one as well, and we are looking at how we can target some of those areas. So, for example, every contact counts, whereby we've got the ability to vaccinate patients wherever they are going across our healthcare system. We're making sure we do that. So there is some further work to do on our strategy with regards to vaccinations, so we can come back in terms of an update on that.
Thank you, Mark. And then Shahina.
Very supportive of the proposal. My question is more post. Will there be a formal post-mortem after the winter ends to say to the board to say what worked well, what didn't work well, did we meet the indicators that we had, and really lessons learned for the following year, so then you can be well prepared for producing the next year's kind of one.
There will absolutely be a post-mortem, which we'll take through execs and into the board. And that was very much our baseline for this year in terms of our lessons learned. So we collect that with hot debriefs after our festive period, another debrief after the winter, and that will go into the overarching feedback. So absolutely, we'll share that.
Thank you, Shahina, and then Mark.
Thank you, Sam. Really enjoyed your presentation. I really enjoyed reading this. Really well planned. You talked about reducing faults using technology.
Have you got your microphone on? Sorry, so that people online can hear.
Sorry, you mentioned the use of technology to reduce faults, and we know that orthopedic cases are so much on the rise during winter. So I was just wondering whether this really is a winter plan or a whole year plan, really.
I think this is a whole year plan, actually, because the interventions that we've put in place, we've been working on these since spring, and they are very much embedded now. So actually, this is a whole year plan, but looking at what we can do for winter to enhance some of those things. So where I've talked about some of the other service levels and the multidisciplinary teams, etc.
Thank you, Mark, and then Neha.
Thank you. Thanks, Sam. Really, again, as with everyone, really good plan. Just the tabletop exercise sounds like a really good idea. Can I just check, are the local authorities going to be at that tabletop?
It covers health and social care.
Okay, so there's representatives.
We've got representatives from all three, a minimum of 2 people.
Fantastic. You think I'd know, wouldn't you? So thank you for that. And then the second one is similar to Joe's point about financial planning. Is there consideration in this in terms of the financial pressures on the authorities? Because it could be that the health side is very well set out and covered, and then if you hit us and our pressures are overburdened, is that going to cause a problem?
And it hasn't taken into consideration any financial burdens. However, within the actual plans, there are the risks associated and there are some mitigations. But looking at Shrewd and our detailed delayed discharges, we will be able to have those conversations from the integrated care transfer hubs around what that potentially may be, so that we can flag that early if there is going to potentially be a risk, and then how we work collectively.
I suspect Sam has a schedule where you're involved from 9 until midday on Boxing Day, Mark. Neha and then Tom.
Yeah, thank you, Sam, once again, very comprehensive. Just a technical question, out of curiosity, so maybe I should ask Emily for that, for Shrewd to display it as well. But how much of that, so that's real time for planning, and a little bit of this planning is based on obviously your baseline from last year, but also some estimations of how we predict, how much of that data from Shrewd after, now I suppose it's going back to Joe's question, how are we assured that that real-time data after the event has passed, everything is actually cross-checked and say, well, actually this prediction or this kind of, trend that was being set is accurate. It's more to a technical kind of improving that particular tool as well, which looks very interesting.
So behind Shrewd, all the data that's collected can articulate into reports. So every one of those domains you can drill down to, and it gives you a past history report and a 24-hour report, etc. So we can go back to check that our assumptions were correct, but actually our decision making against the information was correct. Equally, the bed model from Mid and South Essex Foundation Trust that we use as our barometer, we take lessons learned from the previous year, and those assumptions are applied into that current year as well. So where we may see a length of stay increase, or we may see a demand increase, we incorporate that within the bed model as well.
Thank you. I've forgotten where I was going. Next, always Tom, yes, and then I'll come back to Shahina. Thanks.
So yeah, I think it was just to build on Jeffrey's point actually in terms of vaccination and inequalities, and so I think there is something we need to do in terms of diving a bit more into the data. So I think we obviously look very much at kind of top level cohort data, but actually I think we need to try and get a bit more into that to look at some of the inequalities of access. And one of the things specifically that I've been involved in a couple of conversations this week because the paper's going through health and wellbeing boards is the leader reviews, and so that's looking at the cause of death of people living with a learning disability, and we know respiratory illness is the number one leading cause of death for someone who's living with a learning disability. And I think the indication is that there's relatively low vaccine uptake in that cohort, and so we need to probably, and this is an opportunity, I think, given the focus that we're placing on this, to say what is it we can do through kind of non-traditional routes in terms of promoting access and trying to understand what is the issue with access. Is it vaccine hesitancy? Is it the difficulty of getting to the place where you can get the vaccine? Is it that you don't know that you're eligible? And so, yeah, I think there's an opportunity for us to explore that a bit further and to think about some slightly different ways of working this winter.
Yes, completely preventable deaths from pneumonia and things. Yeah, Shahina.
Really, this is from following from Tom's point and Jeffrey's point. It's really quite important to know the form of communication, for example, to patients. So if patients who are vision impaired get letters that they can't read, and then they miss their appointment, and they miss their appointment again, and they miss their appointment third time, and then they don't get an appointment. And I think this is something we really need to look at in detail. Thank you.
Sam's nodding. Okay, now in a minute I'm going to move us on just for time management. Matthew, is there anything you wanted to add to all this? It's very detailed.
Yeah, I think a couple of points actually, Mike, if I may, and thank you to Sam for your leadership across the system, because I think our reflection at our board meeting when we considered the winter plan and signed the assurance commitment was that the relationships across Mid and South Essex urgent care system are significantly better than they were 2 years ago, and that's demonstrated actually measurable in the reduction in delayed transfers of care and delayed discharges from acute beds. So I think Sam's leadership and others should be really commended for that progress. I think beyond the winter plan, what's really vital is as a system that we really focus on the development of urgent treatment centres at the front of each of our acute hospitals, because the data tells us that many of the people coming to our emergency departments could well be seen in other care settings. And so I think beyond winter, and perhaps in parallel with the conversations, the urgent care transformation programme board really needs to accelerate, I think, that conversation about how we change the fundamental model of care at the front door. Thanks.
Thank you, and people are nodding in absolute agreement with that. Thank you very much, Sam. So you've asked us to note it, to approve it, and then endorse that we send it on upstairs where it needs to go, with it having been signed off, as you say, by the relevant provider boards. Are we happy to do all of that? Yes. Thank you very much indeed. Well done, Sam, and thank you. We now go on to the quarterly communications performance report, and that's Tom and Claire.
Thank you. Thank you, Chair. So this is the opportunity to review the work undertaken by the Communications Engagement Team during Q1 of this financial year. So that covers the months of April, May and June, in line with the objectives set out in the communication strategy, which was agreed at board last November. So I've got some slides here. Sorry, Mike, you might want to move again, keeping you active this afternoon.
Very good.
I'm not sure my clicker's working, actually. Thank you, whoever did that. I'll just take you through some of the kind of key highlights of the report. So in the first quarter of this year, we had a couple of key campaigns that received significant coverage in the local media, and actually some of them even went national. And that was around supporting our campaigns around blood pressure checks, so undiagnosed hypertension and reducing the risk of heart disease and increasing uptake. And some of what Sam said earlier in the winter plan in terms of using that make every contact count approach, and the use of kind of dental practices to encourage patients going for dental care to also undertake a blood pressure check. Now, I'm not entirely sure whether that's a good idea in terms of blood pressure when people go to the dentist, but it has proved really successful, actually. So my scepticism was unfounded, but actually it garnered quite a lot of interest in the media as well. And then in terms of another key priority, which we've supported in terms of coverage, was around pupils getting dental care assessments in schools, and the work we've been doing through oral health education and promoting toothbrushing, and particularly in Thurrock and areas where we know there's kind of issues around oral health in children in particular. Again, good pieces of coverage that were picked up across the board. Oh, now it's going too fast. Actually, talking of the vaccination conversation we've just had is really pertinent to this next piece, because actually for this quarter we were charged with supporting uptake of the spring booster for COVID, and we took up very much that data-driven and the community leaders in those areas to help support that sometimes the generic messaging that we use from a communications approach doesn't sit well with everybody. So actually working with the communities to develop assets for them to share that were much more kind of culturally competent for different groups has worked really successfully. And we've built on a model that we developed through the initial COVID rollout in terms of that, the way that we approach that. And again, this is although it's led by the ICB comms team, we have support from partners across the board, from local authorities, from voluntary community sector, from our providers as well, in terms of making sure that message spread goes through a multitude of different channels. And we were pleased to see the impact it had. There was a 15% increase in the booster uptake, particularly in key PCNs that we targeted in Southend and Thurrock, showed significant uptake from previous spring booster campaign of the year before. So that evaluation is really helpful, and the insight we get from that in terms of planning next stages in any vaccination programme, particularly as we know the hesitancy out there. Saying a similar kind of, again, at a glance approach to our Invincible Feeling, Invisible Danger campaign, which has actually run across the east of England now, and taking that data-led approach in terms of taking a second to check your numbers and know your numbers to help prevent cardiovascular disease. And again, we took a targeted approach using YouTube advertising here, because we know as people are scrolling on YouTube, watching different things, we were able to kind of target different geographies, different locations, adult population of 40 plus, which actually are big YouTube users now. So making sure that we're, again, using the right tactics to meet the audience that we're trying to reach, rather than just that generic messaging that goes out across the board. Although there's a bit of a data lag here in terms of figures, the latest ones do show that the number of people accessing blood pressure checks in pharmacies has been steadily increasing since the campaign launched, which is heartening to see. In terms of our internal comms, as you know, no surprise, given that we're in a period of change, access to our internal comms channels has increased. In this period, this was when the first initial announcement came out, and we stood up very quickly a one-stop place for people to find information about transition and change, and that's continued to see kind of high engagement from our staff. And also our primary care bulletin and comms are well received across the primary care community, and we've seen an increase there again of people accessing information through that. We continue to do our pulse surveys to see what we're doing, and is it working, is it landing with the right people, so we can learn and adjust our approach going forward. In terms of our external communications website, we saw a particular spike in visits. due to the campaigns that we'd been running. So we were driving people to content on the website through our campaigns to make sure they were getting that information. So we can see that that's working through the kind of spike in activity that we can see there. And also we've had a number of new subscribers. So we do a series of email campaigns through our e-marketing bulletins that go out. We've seen an increase in subscribers in this quarter of 1,695, which is great. I won't dwell too much on the news. Had 18 press releases issued and 78 pieces of media coverage generated, so quite a busy period in terms of media. Stories with the most coverage, again, it was the tooth care and the blood pressure checks that dominated the media coverage in that quarter. Engagement, real success story, again, in terms of our virtual views platform, which has been steadily growing. And we hit our kind of one of our key targets of 1,000 people subscribed online now in that engagement space, looking at a range of different topics and filling in a range of different surveys that, again, roll out across the system. They're not just related to ICB programs. We work quite a lot with the Trust in particular in terms of running surveys. And you can see our vaccination survey there, trying to understand what prevents people from getting vaccination, was actually one of the biggest responses we've had so far in terms of surveys on that platform, second only to the MSE patient travel survey. So that was around kind of how people access care and where and difficulties they might have in terms of travelling to hospitals in particular. And then finally, our research engagement network continues to go from strength to strength. We've secured some additional funding in this quarter from NHS England again, and from the National Health Institute for Research. We've run a number of successful events, bringing together groups from different communities to understand how research can benefit both them as a community, but also encouraging participation from those kind of communities that don't usually take part in research. So that's been really, really successful. And again, a couple of pilot programs that we started to run in terms of supporting practices to run virtual PPGs through our Virtual Views platform has grown. So we have now 77 GP surgeries involved with over 70 patients now subscribed as part of those virtual PPGs. So again, going from strength to strength in the engagement world. And that's it, I think, for me from the presentation. Happy to take any questions.
Thank you, Claire. Questions or comments on that? Jeffrey and Lucy.
Thank you, Claire. Always impressive report. So thank you for that. Can we talk about research and engagement network? Yeah, because that's really good. And congratulations on getting another 30K out of NHS England. I haven't included Tom in that congratulations. Congratulations, Claire. So my question really is, and good to see some of the work you're doing with some of the other underserved communities like the Bangladeshi and the Indian communities as well there. My question is, because this can be quite wide, isn't it? Are you trying to target this, given the limited resources? Are you trying to target this in some particular areas of where research needs to be taken up? Some particular conditions, or are you leaving it wide ranging, for example? Just, there's no right or wrong. I just want to hear that. And to what extent are you balancing? Because part of the problem with underserved communities is they want their problem, which is now dealt with now. They're not so much, they are, but it's not a priority to look at 5-10 years. So are you balancing action or signposting with research as well?
Yeah, actually, the beauty of this model is that we initially started out, the driver for it and the driver for the funding came to encourage those communities to take part in research. And you're right, that's great, but actually you want something here and now. But being able to build the relationships with those communities through the research engagement network means we're able to utilise those relationships to help support other things such as outreach clinics for blood pressure checks, vaccination, etc., etc. So it's kind of a win-all really, in that it's enabled us to deepen those relationships. Again, in terms of kind of where we've targeted, we put as much of the money as we can into the community itself, so they have to come up with the schemes and programs that's going to help drive that engagement within their own community. So it's not a prescribed model. We don't go and say, actually, you've got to go and do this with your community. Each of those kind of different community groups comes up with a plan of its own, which they then submit. And we work with Healthwatch Essex as kind of the independent adjudicator, if you like, in terms of where that those funds and grants go. And then we work with them to help deliver it, and any support that they need in terms of delivery, we're there to help and support. So yeah, it's really for them to determine where the areas of need are, or what they want to focus on in terms of supporting, but it also enables them to support their community in a different way as well. Really great example, we have the 7-Day Adventist Church in Thurrock. They do such a lot in terms of the Know Your Numbers campaign, etc., around all of this, and that bit of funding that we've been able to give them to promote research has enabled them to spread more of that into kind of different things that they do. So yeah, it's a really brilliant scheme. You can see I'm quite passionate about it, and you know, Tina in the team and Emmanuel, who have been leading this, you know, they're massively passionate about what they do, and they've built some fantastic relationships with our community groups through it. So yeah, hopefully it will be something that continues even when we kind of spread further. I know there's kind of active work in each of the other areas as well in this case, so if we can join up, even so much the better. Thank you.
And I have to say, if the Seventh-day Adventist Church doesn't know its numbers, there's something wrong. Lucy.
Thank you. And I held off asking this from the previous presentation because I wondered if it would be covered off. And I appreciate the quarter reporting is slightly squiffy because we're actually headed into Q3 now, aren't we? But I was surprised not to see in either our winter plan or the comms plan anything about choosing well. And I know that's an old campaign per se, but we've referenced the fact that we know people underutilise or overutilise different services. We know we've got to redirect from the front door. We know we've talked about pharmacy first and vaccinations, but there is that piece still for me about empowering our patients and families to make the right choice, and indeed our clinicians to redirect people actively, not go, oh, go on, I'll see you because you've turned up here, because I've been there and I have done that myself, but really redirect so that only the people who need to be in A&E end up in A&E.
Thanks, Lucy. And you're right, this is kind of a backward-looking piece, but actually some of our work for the quarter since and continuing now has been working with Sam and the team in terms of developing that whole system winter communication strategy, of which vaccination plays a big part as well. In terms of Choose Well, that's kind of old campaign. It's now help us to help you has been the kind of consistent message that we've had over winter, but actually that's always an always on, what we describe as an always on campaign now. It's not necessarily season specific anymore, because we're always trying to encourage people to get the care they need in the right place. We've also locally been running a really successful Get the Care You Need Quicker primary care focused campaign around kind of almost supporting the demand in primary care as well. You've got pharmacy first, there's other places you can go and get kind of that reassurance piece as well, freeing up, kind of clinicians for those more serious end. So it kind of, it moves the need into another place every time, so that kind of get the care you need quicker. And again, supporting clinicians to have that conversation. So all of that material has gone out across primary care and our providers in that primary care space to help promote that, choosing the right place. What always used to be the Choose Well, but it's, the campaign taglines have changed.
In terms of always on, I was surprised to learn that when we have really, really hot days, A&E peaks with people with sunstroke and things like that. In terms of always on, it's, it's not just winter for that. Anna.
Thanks, Mike. So this, Claire, doesn't directly relate to the report, but I thought it would be a good opportunity to just bring to the board an area of concern that has been coming to me from GP practices around staff of ethnic minorities being sort of targeted in terms of their race and questions about, when are you going home, that sort of thing. So we've had quite a few reports of frontline primary care staff being subjected to racist abuse in the context of the rather febrile sort of situation we're seeing in the community at the moment. And Claire has responded to the concerns by looking at ways that we can address that head on by reiterating the fact that the NHS workforce is made up of people from probably every corner of the globe, and actually they're a very valuable workforce, and without them we wouldn't have a National Health Service. So I just thought we'd raise that here to say that that is something that we're trying to address, and Claire's already responded to the GPs who
Tom
raised
wants
those
to
concerns.
comment on
Yeah.
that.
Yeah, I know it's. I don't think it's just general practice as well. I think we're seeing it across all aspects of health services over recent weeks. So yes, it's something we do need to kind of take head on. And Claire's supporting me, and so I think we will be getting some messaging out, in the next day or two, Anna, on that issue, because that is, some of the behaviours that we've seen are unacceptable in terms of these are people who want to help and people who get up to look after people, and to be subject to, racist abuse is just, utterly unacceptable. And so I think the whole board would join me in terms of reiterating that and our commitment to support people who are unfortunately subject to that.
Indeed so. Giles wanted to come in.
Yeah, thanks, Anna, for raising that. And I think it's just to assure the board that this matter has been escalated now to the National Executive. And I was at a national meeting earlier on this week with a variety of different ICB leaders who have all raised concerns about issues which are happening across the country. So there will be an expectation that something will be coming out from the centre quite quickly and quite strongly about how it's our collective responsibility to treat people with compassion and kindness and without discrimination.
Thank you. I've got George and then Jeffrey, and then I'll need to start moving us on.
Thanks, Mike. Yeah, very quickly. BHRUT launched a campaign recently about physical and verbal abuse with some really smart posters. So before we wait for the national, it's maybe an intermediate solution that we can start, because it was very powerful. So the staff have been a lot more content with that being delivered.
Still a good idea. Up for that, Jeffrey?
Yeah, thank you, Anna, for raising this. Yeah, I think it's good to kind of coordinate upwards as well. But I think, I'm not sure about Essex, but in quite a lot of local authorities, there is a hate campaign group which has got all of the key partners, 16 partners. It's got the police as well involved. So there's something about coordinating at the local level and making sure that we are able to identify and deal with it at that level.
Just from a communications point of view on that point, Jeffrey, I've suggested that we take it to the Essex Communication Group, which covers police, fire, local authorities and health colleagues, because we're all experiencing that in the public sector. So it's what we can do jointly together to kind of get behind that campaign. But in terms of kind of stealing good ideas, we have actually kind of linked up with the BMA and their zero tolerance campaign to really move quickly, because those campaign assets are already there. So we're trying to get those out as quickly to primary care as we can to help support them, but recognising that the support we give as a board to them is just as important as well, to make them feel confident in reporting this.
Okay, thank you. So I need to move us on for time management purposes. You've asked us to recognise the critical role of communications. Thank you. We do. You've heard that. And also to endorse the idea that we prioritise high impact campaigns. And we've now come up with a suggestion of one particular high impact campaign if we're going to make sure that our people out there at the front line are supported in their work, trying to help people don't get abused for their trouble. Thank you, Claire. And I move us on now then to our Chief Executive's report. Tom.
Thank you, Mike. I think it's fairly straightforward, so I'm not going to say too much because I'm conscious of time. There's an update within the report around ICB transition, which I also covered a little bit in the questions from the public. There is one typo board members might have noticed. So it is April 2026 in terms of the formation of the new ICB. But we are obviously working on that. There's an update around the NHS England annual assessment of the ICB, and we'll be talking elsewhere on the agenda in terms of the actions that we plan to take in response to the areas of development. for the organisation. Equally, also, clearly we have seen the publication of the NHS Oversight Framework and Segmentation for Q1, otherwise known as league tables. Obviously, within that, we can see that, you know, as we know, and as we will cover elsewhere on the agenda, we do have some significant challenges in Essex in terms of the relative performance of service in comparison to other parts of the country. You know, that is going to be something that, although there has been some very good work done, there is still a lot more we need to do. And I think one of the things that we will need to challenge ourselves on as an organisation are the plans that we are developing and producing for, you know, next year and beyond sufficient in order to be able to see the improvement in services that local people rightly expect. And then finally, just in terms of kind of some slightly more positive news, the board, you know, will know that we have made CVD, so cardiovascular disease identification prevention, a priority over the course of the past year, and we have now seen the publication of the metrics around hypertension and treatment for atrial fibrillation. So last March, we were 41st of 42 ICBs in England for the proportion of people diagnosed with hypertension who were treated to target. We've seen a significant improvement in that, and we're now 13th. And then equally, we are now second highest performer in the country in terms of the proportion of people with atrial fibrillation who are on treatment. So still a lot to do, but I think it's good to see that where we do, you know, agree a priority and focus on it, we can see improvement. There is still more to be done, as I've said, but that's what we will now move on to. So I think it's a source of assurance, I guess, in terms of, you know, we can see, you know, fairly rapid improvement actually in terms of some key clinical measures, and we know by, you know, we are preventing strokes and deaths as a result of what we are doing, which is great. So yes, so I thought it would be useful also just to update the board on that as well.
Yeah, I mean, given that we have several mountains to climb, it's nice to know when occasionally we have started to climb one seriously, isn't it? Exactly. Questions or comments on Tom's report from people? Okay, well, we know that. It's Tom, in passing, I mean, as we transition to the new arrangements which have been, you know, mandated by government for us to become part of the new ICB, I mean, a huge amount of burden of that, well, all of it falls on you and the whole executive team, and indeed the whole staff within the ICB itself. So can I please recognise that hard work from you, from the executive team, and indeed from all colleagues, not just the hard work, but also because we have to reduce numbers. That's part of the national mandate we've been given. You know, people's lives have been put, their jobs are put at risk, their lives are potentially put on hold by that, and we recognise that still delivering a service which people are on top of that is quite something. So please can we recognise that? Thank you and all colleagues on this path. Thank you, Mike. Matt.
Mike, just on what Tom said, to celebrate cardiovascular successes in particular hypertension program, just putting numbers by that essentially, with those improvements in our percentages, because these are percentages at the end of the day, we're looking at least 60 heart attacks prevented over a 3-year period, up to 100 strokes and 50 deaths, with over 2 million of system savings. So this is real lives, these are real people improving outcomes, and this is what we're about. So it's good to celebrate that.
That'll do nicely, as they say. You know, you just don't want to be on the list. He's just pointed out there. Yes, thank you, Matt. Okay, so we'll move on now then to the quality report, Giles.
Thank you, Chair. I'll take the report as read, although there are some points of change from the time of writing of the report. In relation to the Quality Summit, there has been a decision made by NHS England to defer the summit, so therefore it's not as accurate as written, and we will work with the regional team to convene a following date. And colleagues will be aware that the publication of the paediatric inspections by the Care Quality Commission was released yesterday, and the ICB is working closely with the Trust in relation to the response and the improvement plans in that regard. The other key points just to raise for Board's attention is the national decision to stop the National Maternity and Neonatal Independent Senior Advocate pilot. This is in light of the commencement of the National Maternity and Neonatal Investigation, which will be led by Baroness Amos, and also as well the development of the next National Strategy for Maternity and Neonatal Care. In relation to those families who are currently using the MNISA service, our advocate, who we are giving our sincere thanks to, who has done some absolutely fantastic work with the maternity teams and also with the families, she will now transition that care back into the Trust with appropriate support from specialists within the service, whether they be bereavement midwives, governance leads or other senior leaders within the system, and we will ensure a safe close down. And I think it's important to note the closure of the pilot in no way reflects the work of the MNISAs, and it doesn't prejudge any further decision that will be made as the new strategy for maternity and neonatal services is commenced. And finally, just to complement ongoing work in relation to transition, you will note that there are now a number of good practice documents that have been released, which are to support the Model ICB blueprint in relation to continuing healthcare, special educational needs and disabilities, statutory safeguarding responsibilities and medicines optimisation. Myself and Dr. Sweeting will be acting as the SROs with responsibility to work through the actions that have been identified for ICBs, both within this financial year and next financial year. And of course, we'll be supporting the operational teams that will be affected by the good practice guidance as we move through consultation. I'm happy to take any questions, Chair. Thank you.
Thank you. I mean, Tom and I were at a regional conference which was talking about the MNISAs. I mean, I still can't quite understand the reason for stopping it. It seemed to be working quite well. What am I missing in all of this?
I think, given the nature of the investigation that will be undertaken nationally, and also now the reframing of what the maternity and neonatal strategy was be, it was felt that it wasn't appropriate to continue the pilot. However, it may well be that upon completion of the investigation, it's believed that MNISAs are core to improvement and to ensure the voices of women and pregnant people are heard. So we may well see that they come back. But this is just the cessation of the pilot phase alone.
Okay, and it's not a declaration that was a bad idea? Right?
No, not absolutely not, no. And that was recognised in the NIHR review of the programme.
Thank you. Other questions or comments on the quality report for Giles? No? Okay. Oh, Jeffrey, sorry.
Neha as well.
Oh, and Neha.
Thank you. Thank you, Giles. Can I pick on the model ICB blueprint and particularly pick on the SEN one, for example? And is this looking to, is there a scope there to, for example, pool some of the budgets or joint fund some particular areas so that it can go further with the local authority, for example? Or is that something we're already doing? Can you just let me know?
Yeah, so we're already working very, very closely with our local authority partners in the SEND space. I think this is more in terms of our statutory responsibilities as exists in existing legislation. And of course, any change to SEND would require a change to legislation. So I think it's been quite clear in the SEND space that we will maintain our statutory responsibilities. However, there will, of course, will be an opportunity for us to work more broadly and more widely, potentially across ICBs in the future. But again, there are a series of actions that we will need to undertake in terms of capacity and demand modelling. And as you know, that we are expecting a review and central government direction in relation to the SEND agenda moving forward. That, of course, then will have a further impact in terms of this good practice document. But our relationships with local authorities are very strong, and we absolutely work in partnership with them and also with our education providers to ensure that we're offering the best opportunity for those children with complexity.
Thank you. I think it was Nihat and then Shahina.
Yeah, it's just a comment rather than, not necessarily in the quality papers in the report, but just to highlight some good things also that happen across the system, which we always don't get a chance to, is not exactly the experience of the CVD, but I think we discussed opioid use and management at the last quality meeting, which was actually very positive in terms of we are in the right direction. I think there's plateaued a little bit to some extent, and I was a little bit worried reading the national report, which said actually all the data we have throughout the country is 50% higher than what it is. But despite that, I think the initiatives that were being used and the way it was being managed, including via community pharmacy and so on, to manage to spread awareness was actually quite positive. And it could be, once we have our priority list, something that we could also focus on, because we were quite bad on that and steadily trying to get a little bit higher on that list, in the good list. So just to share that bit of example as well.
Thanks. And there are some communities where it's a really, really major issue, aren't there, with it on our patch. So thank you, Shahina, and then I will need to move us on.
Thanks. So health inequality has been a major part of quality and everything else. It doesn't seem to be part of the model ICB as far as quality is concerned. Where will it sit?
You can go.
It's not listed.
So I think no, health inequalities is a kind of fundamental ambition of strategic commissioning. So to a degree, I think it no longer sits in one portfolio because it's all of our jobs. I think that's a large part of what we've been discussing. In terms of how we've been thinking about it for the future of Essex, it is likely that there will be an executive with that within their portfolio who will ensure it continues to be a priority in the way in which it has. But we may not have necessarily a health inequalities team in the way in which we have had to date, because actually that needs to be embedded into every program that we're doing, and all of us as executive directors need to take responsibility for that, and therefore ensure it's a continuous part of what we're planning, delivering and reporting on, and it needs to be part of our kind of evaluation. And I think, the example that Tom gave earlier around how we use our data to do that, one of the things that is in the model ICB is strengthening our analytical capabilities, strengthening our population health management approaches. And I think that's a really key part of supporting addressing health inequalities, because often it is specific populations who experience those health inequalities, and population health management offers you an opportunity to target support for those populations in a different way. So I think it's part of how we need to change the way that we're working as strategic commissioners, is to ensure it continues to be and is even more so embedded in everything that we're doing, rather than being a sort of program off to the side. Having a framework is really helpful. Having a team, something is really helpful. But actually, with this, you need it to be embedded in everything.
Thank you. And where will it be reported? How will we know it's
so? I imagine we'll continue to have the annual health inequalities report that we've done. So the type of reporting that we've done, I think it's included in our annual report. I would expect that to continue to be the case. I also may be wrong on this, but I think it comes up in our kind of regular performance reporting. And I know that the Trust looks at things like its own waiting list at the moment and has a specific health inequalities focus on that. I think it's at least a couple of times a year you do that deep dive, isn't it? So there's a number of different areas where you get specific reporting, and then also our kind of general health inequalities report.
Thank you very much. So I'm moving on now to finance and performance. Jen.
Thank you, Mike. I will take the report as read. I'll just draw out some of the key points and I'll pass over to Sam to bring the performance element of it to life for us. Just to say, we are, as an ICB, delivering to plan at our month 4 position, and that continues with the headline numbers that I'm seeing for month 5 as well. We have seen some of our risks crystallise, and we have had to manage our mitigations to be able to hold the position where it is at the moment. I would say you'll see the largest figure in those movements is in the acute setting. This was to do with the indicative activity, which came in higher than planned. However, with some further validation, I can assure the board that in month 5, that's starting to come back into line. That was more of a data issue rather than an activity challenge as such. What I would just add, and the board will be aware of, we have seen an adverse movement at month 4, 7 million. The biggest manifestation of that is in an acute setting, which is 6.5 million. I would say the escalation for the our acute hospital for NSEFT, regional escalation has stepped up. Region are already making appearances in the Finance and Performance Committees, and additional escalation is in place. The Finance and Performance Committee are aware of the financial challenges that we're seeing as a system, continue to be concerned, and have requested that the recovery actions that are currently going through the governance are shared with the ICB F&P as well, in order for the F&P to understand more richly the challenges and understand where the ICB can support in that space as we move forward, particularly over winter and getting the position back on plan. So at the moment, the report does talk to us being on plan to deliver, and we haven't changed our forecast outturn. Once we see those recovery actions coming through, I think it's probably fair to say at the moment, we're still planning to deliver our break-even position, but that is incredibly challenged right here, right now. You'll note there is an addition in the report which talks to the Finance and Performance Committee's concerns and escalating them here, and also the request for the recovery actions and cited that here. That's echoed in the performance report as well. So just in the essence of time, I'll pause there, which we might want to move to Sam for performance as well.
Okay, so Joe, do you want to add anything? And then I'll perhaps seek a view from Matthew on what's happening to try and get this back to where it needs to go.
Yeah, I think, Chair, colleagues in the Finance Performance Committee felt that month 4 is a kind of critical time of year. We've got a third of the year burnt, so to speak, and we were obviously disappointed. We know how challenging it is. We recognise that, but we were concerned at that £7 million deficit to understand it. But importantly, what can we do to support recovery? Because if we don't get back, we know future deficit funding will be denied us. So that the hole gets deeper, so to speak. So that was why it was escalated to board. I'll talk about the escalation on performance if Sam or anyone wants me to later, but that's the essence of our financial escalation. Thanks, Chair.
Yeah, so on finance, there's basically a financial penalty for getting your finances wrong to help make everything worse, which is an interesting piece of logic. But Matthew, is anything you want? I mean, is the cause is the overrun workforce? Where is it from?
Yeah, I mean, I think there's pay and non-pay pressure, but I think what we are seeing is the impact of the plan to have delivered more savings in month 4 falling short. We're probably about a month and a half behind where we wanted to be in terms of the particularly the pay spend reductions, and we're really trying to work with our service level teams to understand what is driving an increase in bank spend in medical staffing rotas compared to the same time last year. We've made huge progress around nursing spend. So again, compared to this time last year, we are underspent on nursing overall, but it is medical staff pay that is really driving the position, alongside being about a month and a half behind where we need to be in terms of the Improving Value programme. Turnaround team are working really well alongside us. We've asked them to refresh their approach, so they have changed the alignment of some of their team with some of our teams to if you like, have a set of fresh eyes on things. And this week we've signed off a whole range of immediate stoppages to pay and non-pay spend, in order that the month 6 position is improved as best it possibly can be.
Thank you. I can't remember when the turnaround team sort of, evaporates.
Well, evaporate's interesting. We're sliding scale removal by the end of March, remembering they're not only supporting the financial turnaround, but also the elective and cancer turnaround programs as well.
Okay, thank you. I think that's longer than I thought it was, so that's helpful, actually. Neha?
Thanks, Matthew. Just on the turnaround team, I mean, what's your view that given the deficit that we are facing, was that helpful? I mean, is it that we will see the impact of their council or their efforts in this later on? Is it not shown yet, or we would not expect to be in this place?
Yeah, so remember last year we, as an organisation, delivered significant levels of cost improvement. So inevitably that was focused on more of the low-hanging fruit, but also putting in systems and processes such as moving all of our nursing rosters onto electronic rostering, making sure that we're managing annual leave, managing sickness, all of the availability of staff changes that were driving the bank and agency spend. And the intention for this year was to drive some transformational change around theatres, outpatients and other areas of productivity. Alongside embedding the controlled environment that was lacking in the organisation historically. Clearly, what we now need to do is to go further in forcing our teams to live within their means and therefore reduce their run rate each month. And again, recognising that about 70% of the spend of all of our services driven by pay, and we are a national outlier for the amount of bank doctors that we use compared to our peers. So it's our medical staff pay that's driving particularly the pay overspends. But in essence, the turnaround team have been, in my experience, this is about the third time I've been in an organisation where there are financial challenges. This has been the best approach that this financial turnaround team has taken.
Okay, thank you. May I move us then on to the performance?
Thank you, Chair. Not to reiterate the concerns that Jen has indicated, but the committee do still remain concerned in relation to performance, particularly around the non-delivery of the patient constitutional standards against the national targets and the operating plan trajectories. Whilst saying that, we have had some encouraging progress in some of our pathways. So in cancer, we are delivering against the 31-day decision to treat, which is positive. And we are seeing patients under 18 weeks for first outpatients appointments and a reduction in 4 hours and 12 hours within the emergency department. However, recognising that is against trajectory and it's not meeting national standards. So hence why we do have some concerns that remain. The ICB continues to support our acute trust in terms of interventions and physical, operational and clinical support, targeted funding to increase capacity, redesigning pathways and strengthening operational and clinical leadership within our cancer teams and equally specific tumour sites. Expansion of our clinical capacity through partnership with independent sector providers, and also mutual aid agreements with local providers, and commissioning of services to better referral demand management for RTT pathways. And as we alluded to within the winter plan, the redesign of our emergency department front door models, really focusing on that redesign of patients through to pharmacy first and streaming directly to other services to support that attendance, admission avoidance and overcrowding of our emergency departments to support with those performances. So we are really continuing to support where we possibly can, but we continue to have those concerns from a committee perspective.
Joe, did you want to add?
Only simply, Chair, I think the context for this is that the committee felt, we've got good data. We're seeing the data coming through on a regular basis. It was, or if you like, fluctuating somewhat. But what caused us to escalate on this occasion was some of the trends that are now apparent. And unfortunately, the trends are in the wrong direction. And we didn't feel we could not be doing our job properly if we didn't escalate that concern. Thanks, Chair.
And Matthew, it's kind of in my head, I don't know if this is still going on, that there is some people from a regional team who are sort of coming in and working with your colleagues to address this? I mean, is that misremembering, or are there tricks not working, or what you know, to find ways through this?
Yeah, yes, I mean we're benefiting from NHS England intensive support team assistance, but of course that's generally more focused on diagnosis than it is about own their waiting times and own their waiting lists. The shift in the culture of ownership and accountability is going to be the really important component that will deliver sustainability in waiting times, obviously along with the helpful investment that we've been able to secure both from the ICB, but also from Cancer Alliance and from other pots of revenue funding. It's worth remembering, for example, that in the patch historically, many of our staff delivering core capacity for cancer care were funded non-recurrently with either elective recovery funds or Cancer Alliance funding. That's not a sustainable platform to address cancer waiting times. So with the support of Sam and Tom and others, I think going forward, the organisation will be in a much better position. What we now need to do is to make sure that the additional capacity for diagnostics, particularly with the CDCs opening, delivers quicker diagnosis for our patients. And as Joe said, the ironing out of the variation in some of our specialties that are quite vulnerable to sickness absence or, frankly, in some cases, just not managing themselves properly. So those are the areas that, as Sam has said in her report, that there's a significant area of focus on. But fundamentally, this is about getting capacity that's recurrent and sustainable in order to deliver sustainable change. And I think we're at that point where we're not yet at the cusp where we start to see that really making a difference, albeit, as Sam said, we are starting to see some of the indicators moving in the right direction. But I recognise it's right and proper for the ICB to escalate it to the board. And frankly, sorry, Mike, just to say, you know, it is unacceptable that our patients in Mid and South Essex experience the long waiting times that they do, and we shouldn't be tolerating it. And certainly, I don't, and my board doesn't.
No, thank you. I mean, and faster diagnosis probably will mean that the queues will get longer, won't it? As well, if sadly lots of those turn out to have cancer. Yeah.
Well, that would suggest that it's been poor planning, if that were true. You know, right. we are very clear on the number of patients that need to be, tested. We know we've got challenges in our histopathology service because of the increase in volume, but that's not beyond the wit of good clinical and operational leadership.
Thank you. Matt?
Matthew, just on that really, I guess some of the CQC reports have mentioned clinical leadership culture and behaviour. So it was just to explore, I know there's some internal cultural programmes going on within the trust now. It'd be good to explore that because I think I was chatting with your Chief Medical Officer around that. And number two is some good news. I hear that Thurrock CDC is about to open its doors as well. So just good to explore that.
Yes, I'm doing a tour of all our CDCs at the moment. So I was at Braintree's CDC on Friday, seeing the progress there. So one of the things that we've been wanting to do for at least a year is to put in place a trust-wide organisational development programme that includes helping our clinical leaders to understand what good leadership looks like and their set of responsibilities and expectations, and actually build capability within the organisation. So that's about to kick off. We've been able to secure some funding from national bodies to enable that to happen. And what we're anticipating is that we'll build capacity and capability amongst particularly our doctor leaders, but also other leaders, our team-based leadership model as well, staff engagement being absolutely crucial. But as part of that, we need a clear accountability framework that we put in place to make sure people understand what they're responsible for, what the expectations are, and that they'll be held to account to deliver.
Thank you. I'm going to move us on now because I'm well behind time, but thank you very much for that. And we'll keep in touch with how things are going. Thank you, Matthew. and your colleagues. Okay, so now on to Primary Care and Alliance report, and that's Pam.
Yeah, thank you very much. And I'm here representing my colleagues from the other alliances, Dan Doherty, Alex McCann, and Becky Jarvis, who can't be here today. So want to pay credit to the team's work that sit with those colleagues and the continued effort to do that proactive care work that I think aligns really well to many of the themes that we talked about in the winter plan today, as well as sort of quality and outcomes for the population that we're trying to achieve with health inequalities. You will note that the board paper has quite a focus on the locality that we're sitting in today. So we've referenced a lot of the work for South East Essex. I'm really pleased to say that we've got an outstanding CQC report for a local practice. I'm not saying that doesn't happen often, but it's to be absolutely commended in these times of significant pressure and challenge amongst our colleagues. So something we're very, very proud of. It's a significantly large practice as well, and is one that works with us very, very well. So the patient reported outcomes for that, the patient experience in that practice is very, very good. So well done to Highland Surgery. So that would be noted from the board, I'm sure. We have continued to work with the medium-term financial plan with the focus work around primary care, and we've referenced that in the questions that was posed to us from Peter earlier in the session, and working significantly around our estates work, finance, looking at our commissioning for the future with colleagues in the other areas within Essex around locally enhanced programmes. And for us, there's work to be done around looking at that work. And we took a baseline paper to our executive around what the future might look like and the current state of play. Significant work still to be done on that, but as we form into the bigger Essex footprint, that work will need to be harmonised. We have had a continued improvement on access and patient experience, so that survey is improved again. And colleagues working with us from pharmacy continue to deliver increased access. We've heard that through the session as well around pharmacy first, and that really is starting to be well established. And as we know, the experience for patients going through that remains good. We're very proud of the dental work that we've done here in South East Essex, and notoriety around the care home dental access project has now got to national level. So we've had this since we last met, a number of people from other areas come and ask us, have we done it? What have we done? And starting to inform work around the dental contract for the future. We are working with schools as well for a schools pilot, using a similar model to engage local dentists to work with schools to improve oral hygiene, which is and brushing, which I think is really important. But also lifting the lip, as my colleague David would say, to improve children's experience of having dental interventions. Making sure that they feel comfortable going and don't have the fear of a dentist, which quite often can mean that our children are presenting in A&E with oral issues. So that work continues to be really positive. The paper has reported our first set of dashboard outcomes for integrated neighbourhood teams with the indicators that we've been working not just with our data platforms, but also with our GP practice data and amalgamating that together. So 17 out of the 24 areas for our integrated neighbourhood teams have mobilised frailty. So we went for a whole scale approach in mobilising the frailty project. And that is very, very, encouraging to see the utilisation. I was looking at utilisation of the frailty tool today across practices, and we can absolutely identify where it's being utilised now and start to target where it isn't. Since we last met, the case finder tool has really helped those integrated neighbourhood teams start to identify those high risk patients, frequent attenders, and those with frailty. So all starting to come together in that delivery mode, supporting the proactive care model that will ultimately support Sam's work and reduce the demand further in the system. Some local projects around, we did apply for the National Neighbourhood Health Implementer Programme, and it was South East Essex that we were backing for that because of the data quality, because of the organisation of the integrated neighbourhood teams and the partnership around South East Essex. Unfortunately, we weren't successful in that pilot first phase, but I wouldn't see that as a negative. There was a lot of work getting that project together, a lot of building of sort of commitment, and actually, irrespective of whether you're in phase one, you've got to do it anyway. So that work is not wasted. So whilst it wasn't a green light this time, it was absolutely good work done. For this area, we continue to work around the Sport England project, mobilising Canvey Island for that health, wider determinants of health approach, and also the coastal communities work led by Professor Whitty. So this area is being supported, also looking to harmonise the local investment plan to see how, as partners, we can work together to make sure that we're really addressing the inequalities and the barriers to healthcare. So the BCF, we've continued we take through our local governance, and any underspend or slippage in projects has absolutely been focused on integrated neighbourhood teams, frailty and falls, so that we can have, again, wrap around that single approach to what are our integrated neighbourhood teams doing. I won't steal any thunder from Southend colleagues, because I think there's a mention in there around your CQC rating, but I'll let you talk about that, Mark. But very positive that that rating was good, so you can, that's good for the Alliance as well. So that's it. I'll happily take any questions, but wanted to, as I say, pay tribute to the work done by all the teams and the colleagues that aren't here today.
Thank you. And in fact, both of our local authorities who are here today are sitting in that same glow. And hearty congratulations on your CQC ratings, and well deserved, I'm sure. And we must recognise good news. So well done. Any questions or comments on the Primary Care and Alliance?
Can I ask? So, Pam, what are the chances that the dental care home pilot will become business as usual?
So we have commissioned that within our budget. It's absolutely business as usual now, and we're also doing very, very well against our target for the 700,000 additional appointments across the country. I have no concerns around the delivery of our dental strategy here.
Thank you.
Thank you very much. Yes, Matt.
And Pam, thanks for the report, and I welcome the clear metrics, particularly on the frailty aspect. I know I'm slightly biased with my clinical background as well, but just to say, we are seeing a movement in Mid and South Essex in terms of non-elective admissions to hospital, admissions with falls and fracture in the right direction, sustained over a 2 to 3 year period. Lots of work still to do in lots of zones, but Pam and the team's work to embed frailty at neighbourhood level and build on that with all the other interventions we're doing across the system is encouraging to see, and that's part of that bigger picture. So great that we can see it in black and white now. I know we've got lots of way to still going for our delivery there, but the green sheets definitely.
I think that's a very important point made, Matt, because actually, whilst the data for Mid and South Essex looks lower, actually the work has been being done around sort of outside of the eFracs tool, so we can see that when we log on and start to see what's being done at Rockwood schools, those sorts of things, it may not be being done in the same frailty tool, but actually it's being done. And colleagues from Mid Essex are taking peer support now from other parts of MSE around mobilising their integrated neighbourhood teams, which is huge progress. So we're buddying colleagues up from Central Basildon, the projects that you've seen presented previously, and I think we're at the edge of a really fast go period. So.
Thank you. Question from Jeffrey,
Yeah,
and then I will have to move us on.
It's not a question, it's just a
Oh,
comment,
okay.
Chair, if I may.
Both are welcome.
Thank you. Just, I know the rest of the team are not here, but can we congratulate and commend the success of getting the £20 million from this national fund? And I'm sure many residents in Canvey Island will be really pleased to receive this. Thank you.
Do they get £20 million each? No, but they'll be very happy.
You might never see me.
Pam?
I will pass that on. I think what we've got to remember, this is an extension of the work that we've seen that has made such a significant difference in Basildon.
Yeah.
That also now we'll see it. The outcomes of that is also in culture, is also in classroom attendance. Though Sport England has made a real focus on giving sustainable community development for wider determinants of health, and it's really positive that Canvey Island is now benefiting from that as well, because the trusted processes that we've embedded in those other areas in Essex, the peer support is there, they've been honed, the partners are ready to go. So I think, that 20 million is going to be even more effective than the first 20 million that went through that project. So it's really good news.
Thank you. So we move on now to some items of general governance. I'm not proposing to spend a great deal of time on these. We've got the board assurance framework for noting. If anyone wants to raise anything particular from that, we have to approve some revised constitution and executive committee terms of reference. They've been through other places, so please may we approve those. Someone will tell me if there was any issue. We've got the required review of our board effectiveness, which is there also for noting. We've got some new policies and revised policies. Again, they've been in various places. If anyone has anything, I hope you will say. And we've got approved committee minutes ditto. Is there any other business for part one of our meeting? And if not, then may I say thank you. Thank you to members of the public with this. If you could now leave us, we'll take a small 5-minute pause. If we could keep to that 5 minutes, please, and then hopefully I can bring the meeting in on time.